There is evolving data with ruxolitinib in GVHD. The initial publications were retrospective in nature and really were very promissory, very, very high response rates for individuals who received these drugs in the second or third line setting. We then went on to do formal prospective studies. And the most important one to date is the REACH1 study that was recently published and led to the approval of ruxolitinib for steroid-refractory acute GVHD. It is important to recognize that response rate in that trial was approximately 55%. It was for a group of patients who were relatively selected because they met the entry criteria to a clinical trial. And in fact, the FDA label is based only on the patients who received ruxolitinib for primary refractory acute graft-versus-host disease. Probably more important is the REACH2 study, which is a randomized trial that has completed accrual, but whose data we actually do not know yet. And that was a large trial that evaluated ruxolitinib for steroid-refractory acute GVHD against best available care, or the physician's choice. And the physicians do have a choice of a number of other agents that we can reach for in the setting of acute graft-versus-host disease. And maybe you could just tell us a few agents that we have traditionally used in that setting and how you feel they work in comparison to ruxolitinib.
So we've done a lot of those studies, and unfortunately many of them have good response rates but poor survival. So antithymocyte globulin is an example of that. For steroid-resistant GVHD, there's probably a 60% response rate with antithymocyte globulin and a 20-25% survival. Dr. Cutler and I and our colleague Stephanie Lee did a randomized trial of daclizumab, which is an anti-IL-2 receptor antibody, a number of years ago. Same story. That is, we were all convinced that daclizumab worked great. It was an anti-IL-2 receptor antibody, should really only target activated T cells. We had been using it in very optimistic fashion in phase 2 studies. And then when we did a randomized trial, we found not only did it not work, it actually increased mortality and was less effective than steroid plus placebo. Through the BMT-CTN, the Blood and Marrow Clinical Trials Network, we evaluated 4 drugs to supplement steroids, all of which had been shown in some sort of phase 2 trial to have efficacy. These included pentostatin, Ontac, Enbrel, and mycophenolate mofetil. We initially did sort of pick the winner study that all of the drugs were compared in a 4-arm phase 2, and it turned out that they were relatively similar in efficacy, although the mycophenolate seemed to be a little bit more efficacious and a little bit less toxic. So we then conducted a phase 3 trial, a randomized double-blind phase 3 trial of the combination of mycophenolate mofetil, CellCept, plus prednisone versus prednisone plus placebo. And shockingly, there was 0 benefit to the addition of mycophenolate. So there is no conventional therapy that we know is beneficial in this context. I should point out that although the REACH trials so far have been interesting in steroid-resistant GVHD, nobody wants to treat steroid-resistant GVHD. What you want to treat is up front. You want to use a more effective treatment up front to prevent them from becoming steroid-resistant, and those are the trials that I think will ultimately move the field forward.
And so one of those trials is being conducted now. Actually, several of them are being conducted now. Along the JAK inhibitor line is the trial that's being conducted with itacitinib. And so that is the gravitas 301 study that also has completed accrual. And that, as you mentioned, is a trial for steroid-naive patients who have grade 2 to 4 graft-versus-host disease and who are going to be started on corticosteroids. And so those individuals are being randomized to steroids alone or steroids plus itacitinib. And exactly as you say, the goal here is to increase response rates early on, to reduce the toxicities and the morbidities from corticosteroids, and to prevent more individuals from becoming steroid resistant. As a clinical trialist, it's great to see that we're actually, as a community, doing these randomized, blinded, well-designed, well-controlled studies. And there are studies like these that actually will eventually be practice-changing, we hope. If they're not practice changing because they're negative, then we've learned important things, and we move on to try to do other things, such as more effective approaches to the prevention of acute GVHD, which is in fact one step before more effectively treating acute GVHD, but preventing a larger number of cases is probably the next best step.
Another interesting drug that addresses the regulatory T cell issue to a significant extent is alpha-1 antitrypsin. And this is a drug that also seems to have excellent activity in phase 2 settings. This will be conducted, it hasn't started yet, but will be conducted by the Blood and Marrow Clinical Trials Network in another randomized trial. And this, of course, is not intrinsically immunosuppressive, but it has anti-inflammatory components. It does increase regulatory T cells. So yet another example, along with itacitinib and others, of ways that we may be able to modulate graft-versus-host disease without paralyzing the immune response.